So you found our podcast. We are Mind Beyond the Mission. This is a podcast about veterans and their families, and specifically mental health. What goes on in our lives, what goes on in our heads. We're not talking to you as doctors or professionals. We're talking to you about living with it and what it's like. Brian McKenna, 19 years in the Canadian Forces. I'm joined by my partner, Laryssa Lamrock.
Veteran family member. I'm a proud military brat. My husband served in the military, proud military mom. And we're really excited about this podcast to delve into issues that are important to the veteran and family community.
So join us as we talk about mental health from the perspective of veterans and their families.
Well, welcome back to another episode of Mind Beyond the Mission. And holy smokes, look what the cat dragged in. Brian McKenna, it's really good to have you back in the seat. Welcome back, buddy.
Yeah, it's about time. Couple months of practicing what we preach, and needed to take some time off, get a number of things sorted out, and was dealing with some family stuff. And at the end of the day, if we're going to tell other people that you got to be able to take a knee, well, I did. But we're back at it, and this is going to be an interesting one. We're tackling something that you and I have been talking about for a while, which is sleep. And, you know, at the end of the day, I'd say for me, it was the first thing I really struggled with, whether it's nightmares to a degree, but it was also the fact that I don't think I felt comfortable going to bed. I felt very vulnerable letting the guard down. I think these are things that are really familiar in the veteran community. And we are joined today by Craig Stewart, a doctor from the OSI clinic. We're going to get a bio from Laryssa quickly, but is that how this rolls? Are there sleep experts out there?
Yeah, I mean, I think the term is largely subjective, but I would call myself an expert. I have a background, obviously, in psychiatry, where there's a lot of sleep content in that. But secondary to that, I have a fellowship specifically in sleep medicine. And the standards vary differently depending on what jurisdiction you're in. But the jurisdiction I'm in Ontario, I'm officially certified as a sleep medicine specialist where I practice medicine.
All right, Laryssa, I think it's bio time.
I think Craig pretty much did it. So Dr. Craig Stewart is a psychiatrist with the St. Joseph's OSI clinic, where he specializes in treating operational stress injuries among veterans. He also serves as a sleep specialist, helping patients manage complex sleep disorders through evidence-based interventions, which I'm sure we'll touch on today. With a compassionate approach, Dr. Stewart integrates mental health and sleep science to improve overall well-being and resilience. And boy, do I know how much sleep and mental health, physical health go hand in hand. So Craig joined us actually at the Family Summit in 2025. So please go check that out right after this podcast to hear more. It was an hour session, which went by so quickly, and it was fascinating. A lot of great information that you presented, Craig. And one of the things that you mentioned during that summit that's resonated with me is you mentioned that up to 92% of veterans with PTSD also suffer from insomnia. That number was staggering to me.
It really is, Laryssa. I lead off a lot of talks with that just regarding the prevalence. I try not to get too number heavy, but you know, the anecdote that I always sort of tell is that, you know, we have that DSM-5, which is that psychiatric textbook for diagnoses. And at least, let's say for PTSD, you know, sleep is the only diagnosis, or PTSD is the only diagnosis with sleep as two of the constituent factors to it, you know, nightmares and also disruptions in sleep. And if you look at the prevalence, as you said, the 92%, depends on the studies you look at, but it's one of the most widely reported symptoms of mental health in general, and specifically in the veteran community and active service military for that matter as well. So obviously something near and dear to my heart. It's something we do every day. We spend, you know, a third of our life sleeping. So it's an incredible part of our experience as humans.
So can you maybe start with a little explanation to me as to why is it I struggle to sleep in my bed, but I can sleep just about everywhere else? You know, it's a soldier story. They can sleep leaning up against an armored vehicle. They can sleep in plus 40 under a tree with a root sticking in their back. And then you take us home and there's a place that we're actually supposed to go to bed and our eyes are wide open and we're just not getting it done. What's that about?
Yeah, it's a great couple of anecdotes there, Brian. I hear that a lot in my clinical practice as well, too. When you're in training and it's, sleep while you can, right? And then in the field as well. So we hear that a lot. And what you're referring to probably is most consistent with what we call a conditioned arousal, right? And it goes back to that very old concept of, the dog ringing the bell and it'll salivate, classical conditioning. That's where this conditioning piece comes from. And so many people learn to associate their bed, get conditioned for their bed to be associated with arousal or nightmares or a fear actually of going to sleep. And it's that pairing of those emotions or those thoughts with that physical location that can then precipitate that response. So we hear this all the time. Folks are sleepy and they're drowsy, and then they shut everything off, the phone, whatever it may be, and then they get to the bed and boom, wide awake, right? And it's that pairing of the arousal with the physical location, whereas that arousal is not associated, let's say, with the couch or, with the spare room or wherever it may be.
So first of all, I'd like some credit for recognizing you were just referring to Pavlov's dogs there. Yeah, I'm digging back into high school here to pull that reference out. So are you essentially saying that I've created a situation of sleep anxiety about going to bed in my bed?
It's absolutely possible, Brian. And this is, we talk about habits, right? And how do habits form? Habits form because we do the same thing over and over again. And we might not even notice we're doing it. And then it becomes an entrenched behavior, right? And so I'd probably parse that a little bit and say, you haven't created this necessarily on purpose, but it's developed. And I think that's important, that no one's trying intentionally to create their bed as a place of, arousal, unrest, or mind rumination going, but it happens because you have these intrusive thoughts, you have these nightmares that come in. The night is a quiet time, right? It always has been. And that's when these thoughts tend to come in, when things are quieter, there's less disturbances, the mind is active. And so I said, it's not something intentional that I think you're doing, but absolutely create that habit. And then that perpetuates.
I'm looking forward to unpacking some of those habits and some things that people can do to potentially help them with their sleep. But I'm curious, before we go completely down that road, why so many veterans with trauma struggling with sleep? And I'm even thinking back to, what's the connection with sleep and trauma? And I've heard before that when someone has experienced trauma, if they're sleep deprived going into the trauma, and if they're sleep deprived following the events, that can perpetuate their experience or how they cope with the trauma after. Is there some connection there right from ground zero, Craig?
There is, Laryssa, and it's actually incredibly complex, and I'll try to distill it down because it's something I always struggle with too. And I've asked, people smarter than me about this as well, who work in the field. But the thought is that, these nightmares and intrusive memories get encoded. And, sleep, what is sleep? Why do we sleep? That's a bigger question. We don't know exactly why, but certainly when we have memories, part of the dreaming sleep, part of the processing of sleep helps us to encode memories, both good and bad.
Okay.
And we know that bad memories, these negative emotional valence memories, can actually be encoded much stronger in some cases than positive ones. And so there's a little bit of an uncertainty over exactly the mechanism of what is the connection, let's say, between this rapid eye movement sleep that's associated with dreaming and the encoding of traumatic memories. But certainly, as you said, vulnerabilities in terms of lack of social support, stressors in your life, and lack of sleep can actually precipitate, again, this association, making you more vulnerable to have that negative encoding. On the flip side, and this is getting a little bit down the rabbit hole, is there have actually been studies to show that if you actually sleep deprive somebody selectively of that specific REM sleep after they've had a traumatic event, that actually that can prevent the encoding of the negative memory. And this is where it gets a little bit wonky because things in the brain are not always X plus Y, V equals Z, is that it could equal A, B, C, D, F, G, H, whatever it may be. And so there've been a lot of studies, about trying to figure out, let's selectively deprive people of REM sleep, or let's give them a medicine before or right after the trauma, like a beta blocker that slows the heart down, and we'll see if PTSD progresses or if the sleep is disrupted. And so it's a bit of a mess. So it's not just that simple. So it's always multifactorial. So certainly, as you said, sleep deprivation can play a role for a vulnerability, but then maybe there's also this part that if you don't let people sleep, maybe it ends up better, but it's not something that we would do in clinical practice or try to do, except in an experimental situation, or it just happens naturally.
You know, one of the things I think about when we're talking about the veteran experience is also the fact that veterans are normal people and they go through everything else that people go through, including welcoming new kids into the world. And I think back to, you know, when you finally get that baby home, what's the number one goal really, other than health and safety, is I can't wait till we're all going to bed at the same time. Like at home, it's just a dream for that new parent of like mom and dad sleeping and the baby asleep at the same time. But you go into the military world, and that is absolutely not what we do. We would never have a unit, a functioning group of people, or even down to a section of 8 people. The idea that all 8 of the 8 would be sleeping, it can't happen. And so I guess what I'm asking you is, do you see any circumstances in both in your work life and working through the OSI with a lot of military and a lot of RCMP vets, where they've essentially trained into themselves that someone always has to be awake?
No, I haven't seen so much of that, Brian, necessarily. I think there's an absolute bit of hypervigilance that's there. And it's not necessarily having someone be awake that I see on a regular basis. It's more that people are very attuned to sounds. They're very attuned to safety. They're very attuned to making sure the sleep environment is secure, right? And this starts with things, which I'm sure you're both familiar with, perimeter checks, before the bed, windows are done, locks are done, everything's done. Kids are asleep, their windows are locked, everyone's locked, maybe a double sleep. And, then it's up to bed, and the sleep tends to be very light. And it's this, what we call a low arousal threshold, meaning there's not much that it takes to wake that person up. And that's, I think, comes from this degree of hypervigilance that in some cases, as you said, has been drilled into folks during training, and or then gets exacerbated, or it becomes new when you have some of these well-known traumatic events and people are on guard and they're scanning for exits and all the stuff that, we hear a lot. And that translates into the sleep world as well.
And do you notice a difference between your military and your RCMP cohorts of patients?
Subtly, I think I would notice some of that, and it would be subtle, I think. The differences between the two populations are similar, but then there's also differences. RCMP, a lot of times that we hear about when they do their training, their general duties, where they typically are being sent to a more remote area, they end up doing a lot of shift work, right? Not that that doesn't happen in the military, but they're in a remote location, underserved, 2, 4, 6 of them in the detachment, and you're just not a lot of people power, right? And so they're working a lot of shift work. There's not a lot of backup, and sleep can really get disrupted up there, right? In the military in general, as you said, Brian, you're more in a unit full of folks, and there's a lot more backup, let's say. Not that there can't be shift work, but that's probably the biggest difference that I would see. And in police force in general, talking about first responders, there's a huge amount of shift work that goes on that is just anathema to sleep in general.
So it sounds from day one within policing, within military, there's sleep disruptions. I remember my spouse telling me about QRF, quick reaction force. You weren't really sleeping. And it's, as you mentioned, Brian, someone's always on fire picket, from what I understand. Lack of sleep is part of the job. Then you throw trauma into the mix, and that's perpetuating that lack of sleep. So I'm curious, what are the long-term consequences of insomnia, lack of sleep, flipped circadian rhythm, all those types of things? What's the long-term consequences of that?
Yeah, Laryssa, it's a great question. Thank you for asking that, because I talk a lot about this also in the context of treatment and medications, which we may or may not get into. But more and more, we're recognizing what the burden is of untreated insomnia and untreated sleep. And it's not just worsening mental health, it's increased suicidal ideation, particularly in a circadian piece, actually. There's really good studies that show that suicidal thinking peaks in the early morning when combined with this insomnia.
Wow.
There's physical effects, increased cardiovascular disease, increased metabolic effects like diabetes, right? Early all-cause mortality. And so it really does go back to what you were saying in the beginning there about this mind-body connection, that we're seeing these physical downstream effects. It's not just, you're not sleeping, you'll get a good sleep the next day, right? It really is increasing all of these physical indices across the board. And that's becoming more and more apparent.
So when someone is got a significant sleep issue, what organs are the most vulnerable? What parts of the body would you start seeing negative effects in, other than the fact that the person would feel sleepy, tired, and have a hard time functioning? Like, is my liver got some capacity to repair itself? Do my kidneys suffer more? Does this raise the chance of heart failure? Where do you see this coming through in terms of how our organs suffer due to lack of sleep?
Yeah. And Brian, I'm not sure we have the specific detail to get that granular and talk about which organs and how it may present. It's more like an increased risk factor for things like high blood pressure, like cardiovascular disease, coronary artery disease, and also in terms of diabetes, which is, a multi-organ system as well. But to answer your question, the organ that you notice at first is the brain, right? Mm-hmm. And that's both in terms of physical manifestations such as, reaction time, right? Short-term memory. We've all had that experience where we don't get a good night's sleep and you go to the pantry and what was I getting, right? And so there's those cognitive factors that get affected, but then obviously the mental health piece, irritability, right? And again, lower mood, increased anxiety. So absolutely, I would say it's brain first. The rest of the organ systems are largely, let's say, chronic and over the time in terms of risk factors, but immediately, acutely, we're talking about impact on the brain.
So one thing I'd like to get at a little bit here, more on the myth-busting side, if I'm your patient and I have atrocious sleep hygiene, just not doing any of the things, but I commit and I'm actually going to take your advice now, how quickly do you think you could turn me around into someone that has a proper sleep regimen?
Yeah, Brian, it really depends on, again, the specifics of, who you are, who I'm managing in terms of how severe the sleep disturbance is, what are the comorbid pieces, PTSD, depression, anxiety, are there substances involved? Are there other medications involved? Is there pain involved, right? And so the answer is always individual. And I always say that because people are individuals. No two people are alike, and everyone comes with their own presentation. In general, these days, all treatment you can get done in 8 to 10 weeks, right? Perfect. You'll be fine in 8 to 10 weeks. It obviously varies, but that would be the first line guideline intervention for sort of standard insomnia would be cognitive behavioral therapy for insomnia, which is a scripted 8 to 10 week program where we look at your sleep habits and we change them accordingly through behavioral scheduling as well as some cognitive approaches. So that's the general guideline that we would look for improvement. But again, what is improvement to? I mean, working within a recovery model, we need to set goals that are reasonable. And I think that's one of the things that we encounter a lot in this work is what's our outcome here? People always say when they come to see me, a lot of times it's, I just want to get back to who I was before. I just want to sleep like I was before. And it's part of my job to work with them to recognize, that's probably not going to happen. But let's get to a place where there's some meaningful improvement that's meaningful to you, to the person I'm working with.
I'm imagining veterans and families listening to this and some people going, holy crap, I'm not sleeping. And we were talking about the mental health implications, the physical health implications. I hope that most practitioners explore the sleep habits of any clients, patients that they're supporting with trauma or mental health, whether it's depression or PTSD or anxiety disorders. If not, though, what are questions or what should patients be sharing with their clinicians?
I think it's great. And this is something, Laryssa, actually, that brings up, I do some teaching within the university and I have the medical students ask very specific questions, right? And it's more than just, I don't sleep. This is what I see in my clinical sleep practice, in the community when I do that. And people come in with this chief complaint of, I just don't sleep. And that's a good starter, but it's not a really good descriptor. And so it's my role, and I think as you said from the patient side, to give as much detail as you can. And the role of the clinician too, and we have work to do on this front too. Obviously I'm biased, so I ask very detailed questions about this, but it's beyond what time do you go to sleep? What time do you wake up, right? It's what time is bedtime? What happens then? And we always say this, bedtime 10 and bedtime 8, write down 10 and 8. But maybe the person goes to bed at 10 and then picks up their phone, or maybe they're chatting with their partner, maybe they're watching TV, maybe they go downstairs and have a snack. And then after all, they shut out the lights, and then it takes another hour to go to bed. And now we're looking at midnight, 1 a.m, and that's different from a bedtime of 10 o'clock. And so I think that's the biggest piece, is asking about the bedtime routine and what does that look like? And then one of my biggest questions is, I tell people, tell me how long it takes you to fall asleep once everything is shut down. Once the phone is gone, once you're in bed, once the teeth are brushed, all the above, the TV's off, although the TV may still be on in some cases, how long does it take you to fall asleep at that point? And again, those may be very different answers. And so I think it's helpful if you can bring forth as much detail as possible in terms of the very specifics. How long does it take you to get back to sleep once you're up in the middle of the night? And then what time are you getting up for good in the morning? And sometimes the getting up for good also, I get up at 5, but I'm not out of bed until 8. So it's those real details that can change a lot of the behaviors for me. And those are the targets for intervention in terms of, okay, let's not lie in bed for 5 to 8 in the morning for 3 hours, up and out of bed at 5. And so I think those are the details. Whenever we're looking as clinicians for pieces of history, we're looking at stuff that helps inform the picture, but we're also looking for things to change and things that we can improve on.
I saw the sleep specialist at the OSI clinic in Vancouver, the operational stress injury clinic, for those who aren't familiar with them. And one of the things that he said to me was, there's 2 things you should be doing in your bed. There should be sex and sleep. If you're scheduling in your bed, if you're going over the plan for tomorrow, if you're figuring out who's grocery shopping, who's taking the kids to whatever practice, if you're doing these other things in the bed, his advice was that try limit it to just what's supposed to be happening there and do those other things elsewhere. And he also was reminding me, and I had to admit guilt on this, like, we're people like everybody else. We're as addicted to the phone as everybody else. And at the end of the day, most days when I wake up having had terrible sleep, I have to admit that there was some reels on social media or some doom scrolling that I was partaking in while I was trying to go to bed. How common is that? Has life got worse for us in the world of sleep since we started using the phone as our alarm clock and putting it right beside our bed, pretending we're not going to look at it tonight?
I think it really is, Brian. And, I don't have a data or a study to reference on that, but phones are just so ubiquitous. Electronics are just so ubiquitous now that we hear more about that. And I'm glad that you've talked about, sort of the content and the physical act of doing the doom scrolling. One of the things to get around to your myth busting is that you see a lot of articles about blue light and don't get the blue light from your phone, and this is going to cause bad sleep. And really, the amount of blue light that comes from your phone is minimal. And so for me, it really is this association, like you said, of being awake in bed on your phone, doom scrolling, spending the time awake in bed, not doing those 2 S's, the sleep or sex, and really making that conditioned arousal that you talked about earlier. You're being awake in bed. You're learning to be awake in bed when we want to be asleep in bed. And so as part of best practices for sleep, absolutely, it's shut off the electronics, ideally a half hour before bed, put them aside. But I really would highlight the blue light piece is minimal. It's more this association, the time spent in bed. I think that's the biggest part.
I appreciate, Brian, you talking about, we're real people. Let's bring up the phone. People are looking, doom scrolling. That's a reality. I remember my spouse following Afghanistan. That's how he would go to bed every night is, he was like fixated on it. And I was not very happy about it because I could anticipate what was going to happen then over the night. That's the reality of what happens. So I think Brian and I try and put the realities of what veterans and families are living with into our conversations. And so someplace I'd kind of like to explore, which will kind of lean into impact on families, is the fact that some veterans who want to feel safe and secure might sleep with weapons beside their bed. That's a reality and a conversation that folks need to have. It impacts family concerns. We've talked about I don't sleep in the same room with my spouse. He has like they call it restless leg syndrome, and that's an understatement. It's his whole body, and I would want to throat punch him in the morning when I got up because now I wasn't sleeping. So that's a strategy for us. We don't sleep in the same room. But a lot of families have described getting inadvertently and non-intentionally kicked or punched, things like that. So can we explore that a little bit? I want to talk about it because it's a reality that happens for many veterans and families when we talk about sleep.
It really is, Laryssa. And one of the first things that I learned as I went through my career in sleep medicine was the amount of people who sleep separately, actually, and not even just in different rooms, but in different beds. And these are run-of-the-mill folk, right? Not even, part of a veteran community or first responders or anyone who has this potential to act out at night. So that was a real eye-opener for me. And I think that normalizes it a bit. And I think it's with any community. The more you get into a community, the more you learn about, who's part of that community, that normalizing is important. It's okay to sleep in different rooms. It's okay to sleep in different beds. And there really is this expectation to people sleep in a bed together, and that's the way it should be. It really isn't, right? And I think, again, this points to the individual and what the best practices are. And specifically, this piece about acting out at night, a lot of different names for it: disruptive nocturnal behavior, dream enactment behavior. It really is a potential for danger. Fortunately, I haven't had many significant bad outcomes myself, but there's studies that are awash with these really tragic outcomes, in many cases, serious injury, death even. These are extreme and rare. But it's not uncommon for me to hear from, typically guys who say, I woke up and I was choking my partner, and this happens. And so ideally, as you said, it really is balancing and working with the person, having a weapon around. If they're going to use that in an involuntary state where they're acting out a dream, either going to hurt themselves or others, that could be a really bad outcome. And so it's working to try to make the sleep environment safe enough that we can get rid of that weapon. But even from a weapon, as opposed to a pure-on weapon, I'm counseling people, get rid of the lamp, that's beside the bed, get rid of the alarm clock, get rid of anything that could be used as a weapon, right? Because even something as simple as a lamp, that's going to end up badly as well. So it really is scanning your sleep environment and, making it as safe as possible, balancing that need for safety for the person.
I think one of the things that I've struggled with is you look at what you go through on your own, but you also look at what you put your family through, right? And for the first couple of years, while I was still very highly reactive, my kids actually were trained by their mom how to wake dad up. Very, very similar to the inside Parliament of being like 2 sword lengths away. Well, that was kind of the idea. Was she made a joke of it and taught it to them in a child-appropriate way. But at the end of the day, the moral of the story was you wake him up by touching his foot from as far away as you could possibly stand so you don't get hit. And, realizing that your 5 and 3-year-old are being trained on how not to get hit by dad when he wakes up, that's a hard piece to live with, but that is the reality that we live with.
Yeah, right. And I think that's also part of the overall treatment piece within, psychotherapy and the acceptance and the challenge for the person, who's experiencing those actions to reconcile that. Absolutely. But again, really common to hear that, specifically that piece about, touching the feet and things to that effect. And part of what I counsel my patients is this is not necessarily normal, but expected and part of the disease process. If someone's got PTSD, that comes along with a lot of symptoms, just like other disorders come along with a lot of symptoms. One of those is hyperarousal actions that may not be under your control. And so it really is the education piece, I think, for the person themselves and for the family, and bringing that family piece in to say, yeah, this is not something that person wants to be doing. There's probably a huge amount of guilt and shame associated with that. And putting that on the person is not going to be helpful for anybody. Balancing that again with, these are practical solutions. No one wants to get clocked in the head, either at night or getting woken up. So let's come up with a joint plan to talk about this, make a plan. This is why it's happening. Again, age appropriate, right? I think that's like you said. You're not telling the 5 and the 3-year-old, these are PTSD dreams from so-and-so and so-and-so, and this happened. Make it age appropriate. Like you said, put it into that game part or whatever it may be. And as they become more able to process that, you give them as much detail as they can handle, or you as parents think that they can handle.
So the world of nightmares, one of the things I lived through, I would be scared to go to bed because it wasn't reliving things that had happened. A couple of bad things happened to me, but what would actually happen would be I'd go to bed and my brain would come up with events that actually hadn't happened to me. Things where they'd happened to friends, and then I'd go to bed and I dreamt that I was on that patrol, or I was in the vehicle beside them. And I remember waking up thinking one morning, like, I've got enough bad things in my mind. I don't need a mind that's creating more bad things. Like, if there's 3 nightmares reliving in your life, I don't need 3 more. And my brain was at this point of actually making up stuff. And I would wake up in the morning struggling to actually know if I'd been on that or if my brain had just created. Is that a common thing? Like, what's going on when my brain is actually making new problems for me?
Absolutely, Brian. And I feel like that is another one of these situations that we touched on and brings it back really nicely about what is this role for rapid eye movement sleep, or the dream sleep that we typically associate with dreaming. And part of its function is, we think, is to make sense of memories that happen during the day, right? And, the classic is, you watch the tennis match and you put that together and then you see people's eyes moving left and right in the night. With traumatic nightmares, there's a nice model that I reference frequently that goes through a hierarchy. And one of the key distinctions is what we call thematic memories and replicative memories. Just as it might sound, replicative memories are a replay of specific events that happen to the person and get replayed. Those are actually a little bit easier in some cases to manage with treatment, because you can work within a very nice model to limit those and replay them, actually script. We call it nightmare rescripting to get rid of that. The more thematic ones are these ones that get mushed together, right? And why is that? This is the process that we don't totally understand of the brain making sense of these various memories. And similar to a non-traumatic memory, we have these memories of people riding dragons and spaceships, and how does that happen, right? And it's what the brain does, and it puts things together. It just sticks things together. And there's a lot of different models for this, scientific models, but it's eventually making sense of the disparate threads in our head that are going around and sticking them together. And they don't always make sense when you stick them together in a nice row. And that really explains, what you experience, where you had something happen to you, but there's also something that you knew up from someone else, and the brain at night is cleaning this up and let's stack it together. In the morning, you wake up and go, "Wow, that was weird."
I'm realizing how fast our conversation is going to. There's so much to cover. I was hoping we were going to talk about sleep hygiene, but maybe that's a teaser to send people over to the Family Summit presentation that you did, Craig. It was an hour long and you provided a really phenomenal overview, and you did talk about your thoughts on sleep hygiene. So maybe that's our teaser. And I know that you have a lot of really phenomenal resources that you've recommended. So we'll try and link that in the show notes for the podcast, so people have someplace to go and learn a little bit more and find some helpful resources. I think one of the last questions that I would like to ask is if you could give one piece of advice to veterans or families that are struggling with sleep-related issues, what piece of advice would you give them?
I think it's talk about it. And I think that goes for anything, any mental health concern that we're having. Is sleep is obviously one of the things that's easier to talk about. So there's not as much concern there. It's actually one of the things that the U.S. military at one point in their part of their active treatment is they found that people didn't want to come in and talk about PTSD. So they said, we're just going to talk to you about your sleep. And people were happy to talk about their sleep. And the talk about the sleep led into other pieces as well. And so I think that may be one of the pieces is, if you're not ready to go in and let everything out and have someone, take all the pieces out and dig around and all that things that we think happens, doesn't really happen in therapy quite to the extent that it's portrayed in, some of these popular depictions. Talk about it. Come in and talk about your sleep and see where that leads. But if that's what you're comfortable talking about, start with that. So I would say that is one of the biggest things. And the second thing that I would say is have reasonable expectations. And there's a lot of pressure, again, put on people to get better, right? And this is the stigma of mental health. That is, well, why can't you sleep? Well, sleep is a process that's incredibly complex. We don't understand a lot about it. There's a lot of factors that go into it. And so I think it is having reasonable expectations about okay, let's try to get sleep better. What does that realistically look like? It's not going to be 8 hours where we wake up feeling, fresh as a daisy like we did when we were teenagers, but let's have a realistic goal of what we can improve. And I think that's where providers can really add a lot of benefit to people is, let's look at the nightmares. Let's look at the falling asleep. Let's look at the staying asleep. Let's look at the sleep apnea. And so it really is identifying something specific that could be worked on. And again, I think that takes a lot of the pressure too off of the person in general. And again, this pressure to get better and get everything perfect. Sleep is tough. It happens naturally, but in many people where it's disturbed, it's very unnatural, and it's hard to get back to that natural piece.
So one of the things that I've noticed in the veteran community, it's been said that the ailment of Vietnam was PTSD, and not that it was new because it had been experienced by soldiers going back to Roman times, but it was the military medicine finally coming around to how prevalent it is. And the common discussion about the global war on terror, so the Iraq, Afghanistan, and the modern phase that we find ourselves in, is the military medical world getting its head wrapped around how much mild and medium traumatic brain injury we have. Concussion, compression, the actual physical injuries of the brain. How do you find the sleep is for your patients that you suspect have had an actual physical injury to the brain?
Yeah, it's incredibly complex again, Brian. And that whole area is something I think that is raising a lot of visibility these days. Things like repetitive concussive blasts, these micro blasts as well. And sleep, like anything else, gets affected. And it's really, really challenging with TBI in general. Sleep gets disturbed. And oftentimes the typical interventions that we have, typically medication approaches, don't work as well, or they work kind of funny. They do opposite things that they're supposed to. It's not always the case, but it becomes a very challenging subset of sleep disturbance to deal with when there is TBI. And we don't know enough about it at this point. So it's our standard approach, knowing that there is a TBI involved, but it makes it more difficult overall is the easiest way to put it.
So what are things that I can do just as an individual to have better sleep? It does go into the sleep hygiene discussion to a degree, but I find with a lot of the ailments that are out there, we don't have the thing that the silver bullet that magically fixes it, but there are things that I can be doing to make it easier on myself and easier on my family. What are a couple of those?
Yeah, it's perfect, Brian. Yeah, I'll revisit the teaser to the sleep hygiene. As you said, it's never my favorite term because there is actually no evidence to suggest that sleep hygiene actually helps with insomnia. And so I tend to frame my answers in the term of let's practice principles and practices consistent with cognitive behavioral therapy for insomnia, which is not as nice and neat and doesn't roll off the tongue as well as sleep hygiene. But it involves things like getting up at the same time every day, basically the same time every day. So I'm going to be exact to the minute, but generally within an hour. Getting as much sunshine as you can in the morning. Reset that circadian rhythm with this Zeitgeber, this time giver. The sun is the strongest time giver that we have. Stay active. The body is designed to move, for up to, 12, 16 hours a day. And that's not running marathons. That's just being continually active. So stay active during the day. Go to bed when sleepy. The worst thing you can do to someone who has insomnia is tell them, just go to bed at the same time every day. And I think that's one of the pieces that I have a big challenge with sleep hygiene is if you go to bed at the same time every day and you're not sleepy, you're just looking at the ceiling for hours. And that's right back to that piece, Brian, of that conditioned arousal. You're learning to be awake in bed, not asleep in bed. And so those are the real fundamental things that I always try to highlight with folks. Up at the same time every day, get some sunshine, get out and about, go to bed when sleepy.
I think those are good parting words for people to put into practice. I'm conscious, Craig, that you might have clients at the top of the hour. So I want to thank you so much. I know you're very busy, for making time. We were persistent with you, and I'm so grateful that we were, because this was phenomenal. I think we could talk for another full hour and still not get to sleep apnea or the sleep hygiene misnomers and such. So just thank you again for joining us today. And yeah, Brian, good to have you back. Was it like riding a bike?
To a degree. I mean, it's just nice to get back in the swing of things. And it's how we've always wanted to do stuff on this podcast. We want to bring the experts in to hear what they can advise us and what they can tell us, but also to talk about the real world way that this plays out. Like, how does this actually happen in the community? Craig, I appreciate you. The vets of this country, they've earned it, but they really need dedicated people like you across the country working at these OSI clinics and bringing these different levels of expertise to the table. I hope that through the podcast here that this isn't just a resource that's located in one specific place, or someone thinks they have to go to the Vancouver OSI and see that specific doctor. I hope that people realize that there is information out there, that this is evolving science. In 5 years, we'll probably know more. And probably in a day, we're going to have more questions for you. I appreciate you attending with us today, Craig.
Grateful for the opportunity. As I say, it's always a pleasure to serve those who served.
And this has been another episode of Mind Beyond the Mission. We hope you enjoyed this episode of Mind Beyond the Mission.
If this conversation resonated with you or helped you in any way, I encourage you to subscribe to Mind Beyond the Mission wherever you listen to your podcasts, so you'll be the first to know when our next episode comes out.
And if you know someone who might relate to what we've shared or could find it helpful, please feel free to send it their way. We're all on the same team.
Plus, we'd love to hear what other topics you'd be interested in us exploring in future episodes. Brian and I have a lot of ideas and subjects we plan to dive into, but you, the listener, have probably experienced or thought of topics that haven't crossed our minds yet.
Please reach out if this is the case. We're on social media at Atlas Veterans CA on most platforms. So please feel free to tweet at us, send us a message, or leave a review on this episode, and let us know what else you'd like to hear us talk about.
Brian, it's always a pleasure having these important conversations with you. Looking forward to next time.
You bet, Laryssa. Take it easy.